Hello, I'm Dr. David Torres, and I'm a clinical psychopharmacologist. I'm here to talk about how I do a clinical interview. Psychopharmacologists interview people to find out what makes them tick. We figure out what they want to do and help them do it. When someone walks into my outer office, they see a comfortable tan leather reclining chair. There's a clipboard with paperwork which contains an insurance sheet, a medication sheet, and a rating scale of symptoms. I usually greet the person the moment they come to my office and I ask them for their insurance card. People observe me a lot more closely than I'm observing them initially as I read the insurance card. From the moment I meet them, my mind is at work asking myself the 6 major questions I need to make a diagnosis in order to help someone become their best. In order to help someone become their best, I try to assess by wondering to myself their marital status, their job, or if they have a job, did they sleep the night before, do they have any anxieties, are their thoughts racing, and are they irritable? Are they using substances? I ask the key symptoms that are located on this chart that you see in front of you. First impressions are very important but can be misleading. I assess the person who accompanies them to see if this person is a reliable support or not. It usually takes 3 minutes for somebody to fill out the cycling mood rating scale, and I make a note of it if it takes longer. Taking longer than 3 minutes to fill out a cycling mood rating scale usually means that cognition is not spot on and usually needs improvement. Just as everyone gets weighed in my office to obtain a baseline BMI, the cycling mood rating scale is a baseline screening of their cognition. I review the medication list and rating scale to add to my initial impression, then I ask them what I can do to help them. As they speak, I'm looking for clues that they may have a closed head injury in the past or medical, surgical, or allergy problems with medications. I watch them intently and in a focused manner, and I again wonder to myself if they're sleeping, if their energy is okay, if their level of anxiety is too high or too low, and if they appear irritable or are having racing thoughts. At some time during the interview, I'll put out my hands in front to have the person mirror them to see if they have a hand tremor. Hand tremors speak to a state of overarousal of the norepinephrine system. There are many factors that can cause a hand tremor, and I make a note of the severity of the tremor. Tremors can help determine if someone is having toxicity from drugs, if someone is using stimulants such as coffee. People who are in a highly anxious, hyper-alert state caused by anxiety may have a fine hand tremor. Most everyone will have a fine hand tremor after drinking a Starbucks Grande, which contains 520 milligrams of caffeine. Stabilizing neuronal membranes, which are inherently delicate and adaptable, is a primary task of a psychopharmacology evaluation. My assessment is done in an organized manner so I don't forget to ask anything. If no mention of drugs or alcohol is made, I ask people directly how alcohol and specific drugs made them feel in high school, and I note their response. If their eyes light up, this is indicative of a notable experience. Eyes really are the pathway to the soul, and when someone has a past notable experience, it will give you a lot of insight into how their dopamine pathway is operating in different parts of their brain. I take particular care in asking about drugs and alcohol so as not to upset or alienate people. Responses to drug use questions can provide clues as to whether or not someone's dopamine system is sensitive or insensitive to dopamine-acting medication. Being a psychopharmacologist is often akin to thinking like Sherlock Holmes, in as much as we have to use powers of observation to develop a hypothesis and then to test the hypothesis to see if it works out or not. We have to anticipate the likelihood that a person may develop cardiovascular challenges in the future. We may wonder what kind of fast food a person loves and how much coffee they love to drink. When I see someone in my office for the first time, I often wonder what the likelihood is this person may have a major medical crisis like a heart attack within the next year. This chart shows a list of coronary artery risk factors. Thinking in these terms makes me consider choices of medications based not only on symptom frequency but severity, but on anticipated medical need. The bottom line is assessing what we can do to help a person function at the highest level possible, helping them live longer and more productive life while addressing their immediate concerns. My dietary recommendations for everyone are surprisingly consistent for everyone. Everyone needs to stay away from fast food, except for Subway, no saturated milk fat, high fiber, 50 grams a day, fruit, veggies, hydration diet, no alcohol, no drugs, and they need to keep a list of their medications with their driver's license with them at all times. I ask everyone to eat salad, almonds, salmon, and drink green tea. I tell everyone to stay away from high fructose corn syrup. I also ask everyone to use a barrier method to prevent their getting or giving unwanted disease. I tell everyone my office hours are Monday through Fridays, 8:30 to 5:30, except for 3 p.m., and Saturdays I'm here 10 to 4 p.m. I ask that a person be accompanied to my office so that when they take a new medication, they will have someone with them in case they have untoward side effects. Everyone gets a manufacturer's sheet which comes with any medication I dispense. I use a lot of rating scales in my practice. Rating scales have advantages and disadvantages. On the one hand, they are inexpensive and easy to score. On the other hand, people filling them out may portray themselves in a way that they want to be perceived, resulting in self-report bias. For example, some people exaggerate their symptoms and mark all the symptoms off as occurring all the time. Others may check none of the symptoms off, essentially saying, I have no problems. Not all self-report bias is intentional. People, especially with cycling mood disorders, tend to have challenges self-observing and expressing how they feel. Having an objective third party fill out the scale based on their own observations of an individual can be helpful for a prescriber and the person being assessed. Observer bias, however, needs also to be assessed, as some key symptoms such as irritability may be exaggerated. You can tell a lot about the relationship two people have when rating scales are compared. Rating scales should never be used as the sole determinant of a diagnosis and treatment course. Rating scales are simply a tool to ask better questions and more formulated questions to save time. The Hamilton Depression Scale is an observer scale and needs to be assessed at the time of the initial evaluation to document the degree to which someone is depressed. Someone initially needs to be seen daily until they enter remission, then they can be seen monthly. Exceptions to this are people who have underlying medical conditions who may not be able to get their Hamilton Depression scales below 7, in which case we do the best we can do with recommending a therapist to see the person weekly. If they are a chronic pain patient, an exercise program can desensitize them to pain, which can be helpful. You can learn more about my office practice, my book, and my neuroscience lectures Mondays and Wednesdays 6 to 7 p.m. and Saturdays 9 to 10 a.m. Mountain Time at shrinkharmony.com. From shrinkharmony.com, I'm Dr. David Torres. We'll see you soon.